Usually when we talk about a medical diagnosis, there's this expectation of absolute precision.
Right. We want things to be totally clear-cut.
Exactly. Like, you look at an orthopedist assessing a broken arm, right? The X-ray goes up, and there's this jagged white line slashing right through the radius.
And the doctor just points and says, well, there it is.
Yeah. It's a binary state. It's either broken or it's not broken. It's this clean structural failure that we can literally observe with the naked eye, or, it's a simple scan.
We really crave that kind of diagnostic clarity. We prefer biological systems that act like simple machines.
Like a lever.
Right. A lever is either intact or it is snapped. But soft tissue pathology rarely affords us that kind of mechanical simplicity.
It's just a lot messier.
Very much so. You're looking at a dynamic equilibrium. It's a constant state of cellular turnover and immune response that, frankly, completely defies that binary broken or not broken classification.
And that is the exact transition we are making today for this deep dive. We are stepping out of the realm of clean, calcified mechanics and right into the world of soft tissue.
Into the highly contested anatomical frontiers.
Exactly. We're looking at a structural landscape that is murky to the naked eye, especially when we look inside our own mouths.
You just see a uniform band of pink tissue.
Yeah, and we assume it's just passive filler, just gum. But underneath that surface, a microscopic war is raging right under your lips every single day.
It is the absolute new definition of diagnostic muddy waters. I mean, the oral cavity represents one of the most complex, highly engineered, and heavily defended borders in the entire human body.
So welcome to this deep dive. Our mission today is to explore a fascinating 12-slide presentation that meticulously maps out this exact border.
And it really is a map.
It really is. We are unpacking the presentation titled The Geography of the Gingiva, a macro to micro atlas of the periodontium.
Which is quite a mouthful, but incredibly precise.
Right. And for anyone listening who, assumes something as seemingly mundane as our gums is just a static biological sealant, well, the complex structural biology we're about to cover is going to fundamentally change how you look at your own smile in the mirror tomorrow morning.
It absolutely will.
To ensure we don't miss any of the precise architectural logic of this system, our framework for today is clear. We are going to walk through this presentation slide by slide, and we will actually be reading the exact text of each slide word for word.
Because the terminology in this atlas is highly specific for a reason. But before we even address that first slide, we need to establish the overarching framework here. The periodontium.
Right. Let's break that word down.
Yeah. So if we look at the etymology, perio means around, and dontium refers to the tooth.
So around the tooth.
Exactly. We aren't just discussing the visible gums here. We are analyzing the entire interconnected system of specialized tissues that surround, support, and defend the teeth, starting from the macro stuff we can see all the way down to the microscopic cellular engineering.
Okay, let's establish our map then. I'm looking at the first slide, the title card. The text reads verbatim, The Geography of the Gingiva, a macro to micro atlas of the periodontium.
And the visual here sets the stage perfectly.
It really does. The visual context is this macro, ultra close-up shot of the inside of a human mouth. And the contrast is just stark. You have the rigid, gleaming white enamel of the teeth, surrounded by this highly textured, vibrant pink tissue.
And what's interesting is the specific use of the word geography.
Yeah, that struck me too. In biology, we usually talk about anatomy or morphology.
Right, but geography implies topography. It implies distinct zones, borders, and varying ecological conditions.
Like how Earth has mountain ranges and deep oceanic trenches, right?
Exactly. And specific terrains require entirely different evolutionary survival strategies from the organisms living there.
So by framing this as the geography of the gingiva, the atlas is basically asserting that our mouth is not a uniform, monolithic tissue block.
No, not at all. It's a highly mapped out terrain with very distinct microclimates. Furthermore, the subtitle, A Macro to Micro Atlas, dictates the analytical approach we have to take here.
Because you can't just look at the surface.
Right. In histology and structural biology, you cannot separate the macroscopic form from the microscopic function. The visible mountains and valleys of the gingiva, the macro part, are not just arbitrary shapes.
They're built for a reason.
Exactly. They are dictated entirely by the microscopic cellular engineering, the micro part happening just millimeters below the surface. You really have to understand the specific behavior of individual cells to understand why the visible tissue behaves the way it does under say, mechanical or bacterial stress.
So we are looking at a system where the architecture is built from the bottom up.
Yeah.
We have our geographical framework established, now coming to next slide.
And here we need to define the structural baseline before we can really discuss the defenses.
Okay, slide 2 is titled the Dentoperiodontal Unit. In the center of the slide, there's a line art icon of a tooth, and it's flanked by 2 distinct analytical boxes.
One for support, one for protection.
Yep. The left box is labeled support, and the right box is labeled protection. Let me just read the support box for you, word for word. The periodontium, the functional support unit. The periodontal ligament connects the root cementum to the alveolar bone, tooth socket.
We really need to pause and dismantle the mechanics of that statement because it's crucial.
Yeah, let's break down that functional support unit.
The assumption most people make is that a tooth is rigidly fused to the jawbone.
Like a titanium dental implant, right? Just screwed right in.
Exactly like an implant. But a natural tooth is not ankylosed or fused to the bone.
Wait, it's not.
No. If it were fused, the sheer occlusal force, the biting force of your jaw muscles, would be catastrophic.
Because jaw muscles are incredibly strong, right?
Oh, absolutely. They can easily exceed 200 pounds of pressure per square inch. If the tooth were rigidly fused, the moment you bit down on something unexpectedly hard, the tooth would just fracture, or the surrounding bone would shatter.
Oh, wow. So it needs some give. I know we always hear about the periodontal ligament, or PDL, acting as a biological shock absorber.
It does, but we have to be careful with that analogy.
Why is that?
Well, a standard shock absorber just compresses vertically. Given the multi-directional forces of chewing like grinding, shearing, lateral movements, a simple vertical spring mechanism just wouldn't be enough to stabilize a tooth.
That makes sense. Your jaw moves side to side, not just up and down.
Exactly. You are hitting on the precise biomechanical brilliance of the PDL here. It is less like a simple spring and much more like a highly complex tensegrity structure.
A tensegrity structure.
Yeah, the periodontal ligament is composed of dense bundles of type I collagen fibers, and these fibers don't just run straight across from the bone to the tooth.
How are they arranged then?
They are arranged in highly specific, organized groups. You have oblique fibers, apical fibers, horizontal fibers. They sling the tooth into the socket in a way that actually suspends it.
Spends it. Like a hammock.
Exactly like a biological hammock. When you apply downward pressure, the oblique fibers actually stretch and pull upward on the alveolar bone.
That is wild.
It really is. They convert compressive force into tensile force, which bone is much, much better equipped to handle.
So the tooth is essentially hanging in this microscopic, multi-directional hammock. And the text mentions 2 specific anchor points for this hammock: the cementum and the alveolar bone.
Right. So the cementum is a specialized avascular tissue that covers the root of the tooth. It's biologically designed to allow the ends of those collagen fibers, which are called Sharpie's fibers, to embed themselves directly into the root surface.
Like ropes tied to the side of a ship.
Precisely. And on the opposite side, the alveolar bone forms the socket itself, and that bone is highly vascular and reactive.
Reactive meaning it changes.
Yes. This entire unit, the bone, the ligament, and the cementum, relies on constant mechanotransduction.
Meaning the physical movement sends a signal.
Yes. The physical strain placed on the ligament during chewing literally tells the bone to maintain its density.
Use it or lose it. Okay, so that covers the underlying mechanical support. Let's look at the right side of the slide, the protection box. Reading word for word here. The gingiva, the protective armor. Its primary function is to shield the underlying supporting tissues from the harsh oral environment.
The harsh oral environment, we throw that phrase around a lot.
We do. But from a strictly biological standpoint, what makes the oral cavity so uniquely hostile compared to, I don't know, the lining of the stomach or the respiratory tract?
Well, the oral cavity is subjected to a combination of extremes that basically no other tissue bed in the human body has to endure simultaneously.
What kind of extremes?
First, consider the severe thermal cycling. I mean, you might consume a cup of hot tea at 140 degrees Fahrenheit, and then 10 minutes later, you might drink ice water at 35 degrees.
Oh, right.
And biological tissues and calcified structures have different coefficients of thermal expansion.
Meaning they shrink and swell at different rates.
Exactly. The enamel expands and contracts at a different rate than the surrounding soft tissue, which creates microscopic stress right at the border between them.
And then you have to add the mechanical shear force to that thermal stress.
Precisely. Think about the friction generated by masticating a piece of crusty bread or biting into a raw carrot.
That's a lot of abrasive force.
Massive abrasive shear forces directly against the soft tissue. If you applied that same consistent friction to the skin on your forearm, you would quickly develop an ulceration.
Ouch. Yeah.
And then on top of all that, we have the biological assault. The oral microbiome consists of hundreds of distinct bacterial species.
Right. Billions of bacteria.
And they are constantly forming these complex biofilm matrices, what we call plaque, on the non-shedding surfaces of the teeth.
So the gingiva is tasked with sealing off a highly vascular, sensitive ligament system from wild temperature swings, violent mechanical abrasion, and an endless siege of opportunistic bacteria.
It is the ultimate shield, and if that biological seal fails, the bacteria just migrate right down into the periodontal ligament space.
Which causes an infection.
Yes, and the resulting immune cascade actually causes the alveolar bone to resorb, to melt away basically, to escape the infection. The ligament detaches and the mechanical support system collapses.
Wow.
The tooth is lost not because the tooth itself failed, but because the protective armor failed.
Which means we need to meticulously map out this armor. Now coming to next slide.
Right, we are moving from the conceptual unit to the visible geography.
Slide 3 is titled Mapping the Macroscopic Gingiva. The visual provided here is a clinical close-up photograph of human gingiva being evaluated with a metal periodontal probe.
The tissue looks very healthy there, a nice stippled pink.
Yeah, it looks like an orange peel texture. The slide features 3 distinct map legends pointing to different architectural zones. We read the text from map legend 1. Marginal gingiva, collar. The unattached terminal edge surrounding the teeth, often demarcated by a shallow free gingival groove.
The term unattached terminal edge is really the critical physiological feature to note here.
Because it's a collar, like the collar of a turtleneck sweater.
Right.
Right. It wraps around your neck, but it isn't stitched directly to your skin.
That's a perfect analogy. The marginal gingiva forms this cuff around the neck of the tooth, but the very top millimeter or so is not physically bound to the underlying bone or the tooth surface. It's actually freestanding tissue.
But if it's unattached, how does it maintain its shape against the tooth? Why doesn't it just, flop away from the enamel?
It's remarkably well engineered. It maintains its tight adaptation through a combination of dense circular collagen fibers within the tissue itself.
Like a biological drawstring.
Exactly like a drawstring pulling the collar tight. And that's combined with the hydraulic pressure of the fluid dynamics within the underlying tissues.
Oh, interesting.
And you see that shallow, free gingival groove mentioned in the text. That's a slight depression on the outer surface of the gum. Histologically, it often corresponds to the exact level of the bottom of that unattached collar, basically marking the transition to the next geographical zone.
Which brings us to map legend 2. The line here points below the collar to the broader band of tissue. It reads, attached gingiva, the anchor, firm, resilient, and tightly bound to the underlying bone. Width increases with age and is greatest in the maxillary incisors.
So if the marginal gingiva is the flexible collar, the attached gingiva is the immovable foundation.
Why does it need to be immovable?
Mechanically, you just cannot have loose mucosa directly adjacent to the teeth. When you bite into an apple, the bolus of food is deflected off the crown of the tooth and crashes directly into the gingiva.
Ah, so it needs to resist the pull of chewing.
Exactly. The attached gingiva is bound tightly to the periodontium, which is the fibrous membrane covering the bone via dense connective tissue fibers. This prevents the frictional forces of chewing from simply stripping the soft tissue right off the jawbone.
That makes total sense. Now, the slide specifies 2 really fascinating variables here. The width increases with age, and it is greatest in the maxillary incisors.
Both very important clinical facts.
Well, I understand why the maxillary incisors, the top front teeth, need the widest anchor. They guide the jaw during incisive movements and take the brunt of the shearing forces when we bite into food.
Yes, they do the heavy lifting for biting.
But why does the width of this anchor tissue increase as we get older? That seems odd.
It's actually a process driven by something called continuous passive eruption.
Passive eruptions.
Yes. Throughout our entire lives, our teeth undergo microscopic amounts of wear on the occlusal or biting surfaces, just from daily use. To compensate for this wear and keep the upper and lower teeth in proper contact, the teeth very, very slowly continue to erupt outward from the bone.
Wait, our teeth are always erupting?
Slowly, yes. And as the tooth moves, the attached gingiva moves with it, slowly expanding its zone of keratinized tissue to maintain that protective barrier. It is a highly dynamic, lifelong adaptation.
That's incredible. Okay, moving to the final zone on this slide, Map Legend 3. The line points deeper into the vestibule of the mouth, where the tissue becomes noticeably darker, redder, and clearly more vascular.
You can often see the little blood vessels there.
Yeah. It reads, mucogingival junction, the border where the firm attached gingiva meets the loose, movable alveolar mucosa.
This is a really sharp anatomical fault line.
Why such a sharp border?
Because the oral cavity must serve dual, totally conflicting functions. It has to be a rigid, fortified bunker to handle mastication, which is exactly why we have the attached gingiva.
Right.
But it also must be a highly flexible, dynamic cavity to facilitate speech, swallowing, and facial expressions. I mean, if all the tissue in your mouth were tightly bound to the bone, you couldn't move your lips or puff your cheeks.
So you need firm tissue near the teeth, but loose tissue further away.
Correct. The alveolar mucosa is engineered for high elasticity and movement, completely lacking that tight periosteal attachment. The mucogingival junction is the exact genetic and structural boundary where the heavily armored, immovable tissue abruptly ends and the highly vascular, elastic tissue begins.
It's a literal borderline.
And clinicians monitor this junction closely, because if bacterial disease or even aggressive toothbrushing destroys that band of attached gingiva, the loose alveolar mucosa is just not engineered to withstand the mechanical stress of eating.
Which leads to receding gums.
Exactly. Severe gingival recession.
Okay, so we have mapped the outer walls. We need to look at the space between the wall and the tooth. Now coming to next slide.
This slide brings us to what is arguably the most clinically significant microscopic space in the human body.
Slide 4 is titled The Gingival Sulcus, the moat. The descriptive text defines it as a V-shaped shallow crevice between the tooth and the free gingiva, extending down to the junctional epithelium.
A literal biological moat.
I love the moat analogy, the space between the castle wall, the gum, and the castle itself, the tooth. The visual here shifts to show a calibrated periodontal probe inserted directly into this hidden space between the tooth and the gum line, right alongside a ruler graphic.
Let's analyze the measurements on that ruler.
Yeah, looking at the scale here, the top scale points to 0 millimeters with the text box, a 0 millimeter ideal germ-free, seen only in germ-free animals. And then the lower bracket encompasses 2 to 3 millimeters reading. Clinically normal, standard probing depth in humans.
That disparity between ideal and clinically normal is huge. It reveals the profound impact of our microbiome on our baseline anatomy.
How so?
Well, when we look at gnotobiotic animals like laboratory mice raised in completely sterile, germ-free environments, we see that the gingival tissue attaches to the tooth all the way up to the very top edge of the collar. There's virtually no sulcus. It's a 0 millimeter depth.
But the human mouth is not a sterile vacuum.
Far from it. From the moment of birth, we are colonized by complex microbial flora. And those bacteria immediately seek out the physical seam where the soft tissue meets the hard enamel. They colonize that specific junction.
Even if you brush perfectly.
Even with pristine oral hygiene, a baseline level of plaque biofilm forms. And the host immune system recognizes these bacterial antigens and mounts a response.
So the body fights back immediately.
Yes. This continuous low-grade inflammatory infiltrate causes the very top portion of the epithelial attachment to break down slightly. The tissue literally steps back from the tooth, creating that 2 to 3 millimeter V-shaped crevice.
Wait, hold on. If the presence of bacteria causes the tissue to detach and form this moat, why doesn't the immune system just, escalate the response, eradicate the bacteria completely, and reattach the tissue to achieve that 0 millimeter ideal? Why tolerate a 2 to 3 millimeter gap at all?
Because complete eradication of the oral microbiome is biologically impossible and, honestly, evolutionarily undesirable.
Because some of the bacteria are good.
Exactly. Many of those bacteria are commensal. They actually outcompete deadlier pathogens. The immune system is not aiming for sterility, it's aiming for homeostasis.
A balance.
A 2 to 3 millimeter sulcus represents a stable standoff. It's deep enough to harbor the commensal biofilm, but shallow enough that the outward flow of gingival crevicular fluid, which is a serum-like exudate that constantly flushes the moat, can physically wash away metabolic waste and loosely attached bacteria.
Oh, wow. So when you're sitting in the dentist chair and the hygienist is taking those measurements and calling out numbers like 223, they are confirming that this specific immunological standoff is stable.
Precisely. They are verifying the truth. But if they measure a 4, 5, or 6 millimeter pocket, it means the bacteria have broken the stalemate and are actively migrating down the root surface, destroying the ligament.
So a deeper pocket is literally an anatomical failure.
Yes, it creates an anaerobic environment where highly pathogenic, oxygen-hating bacteria can thrive totally out of reach of a toothbrush, which accelerates the destruction of the periodontium.
That is terrifying, honestly. Okay, so we've looked at the moat wrapping around the front of the tooth. But the geography changes wildly when we look at the spaces between the teeth. Now coming to next slide.
Right, the interproximal architecture. This introduces an entirely new set of biomechanical challenges.
Slide 5 is titled The Interdental Gingiva. The subtext reads, occupying the embrasure space between teeth, this tissue acts like a specialized anatomical tent.
The visual diagrams here are really helpful.
Yeah, they're fascinating. We see cross-sections of different teeth, a molar, a premolar, and an incisor, detailing how the gum tissue fills the empty void between adjacent teeth.
Notice how the tissue adapts completely to the shape of the teeth.
Right. Let me read the structural labels. First, the peaks. Facial and lingual papillae, the peaks, formed by the continuation of the marginal and attached gingiva.
So if you view a healthy mouth from the front, you see these distinct, knife-edged pink triangles pointing upward between every single tooth.
Like little mountain peaks.
Exactly. Those are the facial papillae. And there is an identical set of peaks on the inside of the mouth facing the tongue, the lingual papillae.
What's their purpose?
They are engineered to completely fill the embrasure space, preventing food impaction during chewing.
But the peaks are only half the story, according to this slide. The second label points to the hidden anatomy connecting them. The valley, it reads. The coal, the valley, a depression that connects the facial and lingual peaks directly under the contact point of two teeth.
The coal. This is perhaps the most vulnerable geographic zone in the entire periodontium.
Why is that?
Well, structurally, it is a saddle-shaped depression stringing the two peaks together. Its 3D geometry is entirely dictated by the morphology of the adjacent teeth.
Yeah, looking at the diagrams, the coal between two massive molars is extremely wide and broad, like a shallow basin. But the coal between two narrow front incisors is a sharp, tiny dip.
The tissue seems to perfectly adapt to whatever space is available.
But how does that make it vulnerable?
It adapts because the shape of the caul is molded by the contact point of the teeth above it. But this exact location, directly beneath where two teeth touch, creates a profound weakness.
Because you can't reach it.
Partly. Because the tissue is sheltered by the contact point above, it doesn't receive the mechanical friction of food brushing against it during chewing.
Oh, I see.
And as we will see in a bit, tissue that doesn't experience friction doesn't develop a hardened keratin armor.
So the coal is this hidden valley of unarmored, non-keratinized tissue situated exactly in the hardest to clean area of the mouth, where bacterial plaque stagnates perfectly between the teeth.
Precisely, which is why the overwhelming majority of periodontal lesions gum disease originate right in the coal. It is the weakest point in the castle wall.
But wait, what if that contact point between the teeth simply isn't there? What happens to the valley? Now coming to next slide.
This illustrates the absolute reliance of the soft tissue on the hard tissue. It's a great principle.
Slide 6 is titled The Diastema Exception. It provides a clear definition. Diastema, a space or gap between two adjacent teeth.
Like a gap in the front teeth.
Exactly. We have a photograph here showing a prominent gap between two upper central incisors with the interdental gum tissue highlighted. Let me read the core takeaway text box. Core takeaway. The coal relies entirely on the presence of adjacent teeth. In the presence of a diastema, the interdental papilla disappears completely.
This is a masterclass in the biological principle that form follows function.
So the tent collapses.
Yes, the interdental papilla, the peaks in the valley, is not an innate genetically predetermined shape. Its architecture is purely reactive to the physical environment.
If the tissue is purely reactive, what is the exact mechanism that causes the tent to collapse when a gap is present? Like if I have a tooth extracted or if my teeth separate naturally, why doesn't the gum tissue just stay pointy?
Because of mechanotransduction at the cellular level?
There's that word again.
Yes. The fibroblasts, which are the cells responsible for building the collagen framework of the gingiva, rely on constant mechanical tension to know where and how to lay down their structural fibers.
So they need to feel the pull.
Exactly. When two teeth are touching, the transeptal fibers that run between them create a specific web of tension that suspends the papilla, literally pulling the peaks up and defining the valley beneath the contact point.
So when the teeth separate or tooth is lost, that web of tension simply snaps.
It's gone. Without the mechanical support of the adjacent tooth surfaces, and without the tension of the transeptal fibers, the fibroblasts stop producing the localized collagen matrix.
And what happens to the tissue that's already there?
Matrix metalloproteinases enzymes that break down tissue begin to remodel the area. The highly specialized peaks and the hidden coal simply resorb. The tissue flattens out, reverting to a basic, heavily keratinized band of attached gingiva that rolls smoothly over the bone.
Wow. The structural complexity only exists because the physical constraint of the adjacent teeth demands it.
Form follows function.
This is incredible.
Well,
But to truly understand how these fibroblasts and cells operate, we need to leave the visible world behind entirely. We need to go subcellular. Now coming to next slide.
we are crossing the threshold now from macroscopic geography to microscopic engineering.
Slide 7 marks a really dramatic visual shift. The title is Beneath the Surface, the microscopic view. The image is this complex, glowing, schematic concentric layers of cyan and gold that look almost like a cybernetic model, or like the atmospheric cross-section of a planet.
It's a beautiful way to visualize the histology.
Let me read the structural brackets. The innermost sphere is labeled central core, composed of dense connective tissue, and then the thick layers wrapping around that core are bracketed as stratified squamous epithelium, the biological armor protecting the core, divided into 3 specific types: oral, sulcular, and junctional.
So this schematic represents the fundamental blueprint of the entire gingival system.
Everything we just talked about.
Everything, every piece of visible geography we just mapped, the collar, the anchor, the caul, the moat, is constructed using this exact 2-part histological arrangement.
Okay, let's isolate the central core first. The slide calls it dense connective tissue, which clinically is referred to as the lamina propria, right? What is actually housed inside this core?
The lamina propria is the living metabolic engine of the gingiva. It's a dense matrix primarily composed of type I and type 3 collagen bundles, suspended in a gel-like ground substance of hyaluronic acid and proteoglycans.
Sounds very robust.
It is, but more importantly, it houses the neurovascular bundles. This is where the capillary loops reside, delivering oxygen, nutrients, and immune cells. It's also where the nerve endings dictate sensory input.
And crucially, the epithelial armor wrapping around this core does not have its own blood supply, right?
That is a critical point to understand. Epithelium is entirely avascular.
So it doesn't bleed.
Right. The trillions of cells making up the outer armor rely exclusively on the diffusion of oxygen and nutrients across the basement membrane from the capillary loops down in the central core.
Which means the core is essential for life, but highly vulnerable.
Extremely vulnerable. If the oral environment, the mechanical shear forces, and the bacterial acids we discussed breach the epithelium and hit the lamina propria directly, it would result in massive hemorrhage, rampant infection, and immediate tissue necrosis.
Therefore, the epithelium must act as an impenetrable, self-renewing shield. The term stratified squamous dictates the strategy here.
Exactly. Let's break those words down.
Well, stratified indicates a multi-layered defense, right? Preventing a single scratch from compromising the whole system.
Yes. And squamous refers to the flattened, scale-like shape the cells assume as they reach the surface, which maximizes their barrier surface area.
Like overlapping shingles on a roof.
Perfect analogy. And as the text notes, this armor is highly customized based on its specific location. Oral, facing the mouth, sulcular, lining the top of the moat, and junctional, sealing the base of the moat.
Okay, so let's examine how the outer wall builds its specific type of armor. Now coming to next slide.
This next slide is where we see the biochemical assembly line of the primary defense mechanism.
Slide 8 is titled The Oral Epithelium Layer Cake.
I like that layer cake.
Yeah. The visual is an intricate hand-drawn biological cross-section displaying 4 distinct stacked cellular layers resting on top of the central core. I'm going to read the text for each layer from bottom to top, tracing the life cycle of these cells.
Excellent. Let's start at the foundation.
The foundation layer reads, basal layer, stratum basal germinativum.
So the stratum basal is a single layer of cuboidal cells resting directly on the basal lamina, which is the basement membrane separating the epithelium from the connective tissue core.
And what does germinativum mean here?
The word germinativum indicates its function. This is the proliferative compartment, this is the birthplace, these are the stem cells and amplifying cells. Through continuous mitosis, they divide.
So one stays and one goes.
Exactly. One daughter cell remains in the basal layer to divide again, while the other is pushed upward, beginning a specialized journey of cytodifferentiation.
As it gets pushed up, it enters the second layer. The text reads, spinous layer, stratum spinosum. It highlights two components here, crickle cell layer and tonofibrils.
As the cells migrate into the stratum spinosum, they undergo a major morphological change. They become larger polyhedral cells.
And why is it called the prickle cell layer?
Well, historically, under early microscopic fixation techniques, the cells shrank. But the strong intercellular connections holding them together did not, giving them a spiky, prickly appearance.
Oh, that's interesting. What are those connections?
Those connections are desmosomes protein complexes that literally rivet the cells together to resist mechanical shearing.
Okay, and what about the tonofibrils? The text mentions those.
Tonofibrils are the internal structural reinforcement. The cells begin synthesizing massive amounts of intermediate filament proteins, specifically keratins K1 and K10.
Like biological rebar.
Exactly like structural cables or rebar, these keratin filaments bundle together into tonofibrils, spanning the interior of the cell and anchoring to the desmosomes, creating a contiguous, highly tensile network across the entire tissue layer.
Wow, so they are building their own internal armor as they move up.
They are.
Moving up to the third layer, the text reads, granular layer, stratum granulosum, and details, keratohyalin granules, membrane-coating granules, and granular intermediate layer.
The biochemical factory really hits its peak here.
How so?
The cells are becoming noticeably flatter now. They begin packing their cytoplasm with dense keratohyalin granules, which contain a protein called profilagrin.
Okay.
They also produce membrane-coating granules, sometimes called Odlen bodies. These are critical. They migrate to the cell membrane and exocytose, basically dumping liquid-rich contents into the intercellular space.
Lipids, so it's like waterproofing.
Exactly. This creates an absolute waterproof biochemical seal, preventing fluid from leaking out of the body and preventing water-soluble bacterial toxins from getting in.
The cell is sealing the environment, but it's also preparing for its final transformation, right? Because we have the top layer now. The text reads, keratinized layer, stratum corneum, keratinized surf layer. The visual shows flat, tightly packed bands with no visible nuclei.
Right, no nuclei. This is the culmination of cytodifferentiation, cornification.
Cornification, which means what exactly?
It is a highly specialized form of programmed cell death.
Wait, they die on purpose?
Yes. The profilagrin from the granules converts to filagrin, which acts like molecular glue, aggressively bundling the keratin tonofibrils together until they completely fill the cell.
And then what?
The cell membrane is replaced by a highly resistant, cross-linked protein structure called the cornified envelope. The nucleus and all internal organelles are degraded by enzymes. The cell dies, leaving behind a solid, flattened brick of pure structural protein.
The stratum corneum is literally a layer of heavily armored, dead cell corpses standing between the oral cavity and the living tissue below.
It sounds gruesome, but it's brilliant engineering.
It's like a factory assembly line, where cells start raw at the bottom and get packed with armor and flattened out as they're pushed to the surface. But how fast is this factory running? Now coming to next slide.
The kinetics of this system are going to shock you.
Slide 9 is titled The Keratinization Elevator. The subtext reads, keratinization is an active sequence of biochemical and morphological events. The visual here overlays a massive glowing upward-pointing arrow onto our layer cake, labeled the elevator.
Let's break down the steps.
Let me read the step-by-step breakdown.
Yeah.
Step 1. Principal cells, keratinocytes, are born in the basal layer. Step 2. As they migrate upward toward the surface, they synthesize keratin. Step 3. They form the tough, protective outer shield.
We must emphasize the subtext there, an active sequence.
Because it's not just passive.
Exactly. The older, incorrect model of epithelial differentiation assumed that cells simply degraded and dried out as they were pushed further away from the blood supply in the central core, just passively turning into dead squames.
But that's not what's happening.
No, cortification is a highly energy-dependent, genetically programmed sequence.
Well, yeah, it takes immense metabolic energy to synthesize those tonofibrils, manufacture the lipid granules, and cross-link the cornified envelope.
Exactly. The keratinocytes are actively executing a complex genetic program, guided by shifting calcium gradients within the tissue layers, and the speed of this elevator is remarkable.
How fast are we talking?
The turnover rate for the oral epithelium. So the time it takes for a cell to be born in the basal layer, travel up the elevator, become a dead keratinized squame, and eventually shed off into the saliva is approximately 10 to 12 days.
10 to 12 days. That is incredibly fast.
Compare it to the epidermis of your skin, which takes roughly 28 to 30 days for complete turnover.
Oh, wow.
The oral cavity is so physically destructive that the gingiva must regenerate its outer armor almost 3 times as fast as normal skin just to maintain its integrity.
So the body is burning massive amounts of energy to maintain this impenetrable keratinized shield on the outside of the gums.
But as we established earlier, the geography changes when we drop into the moat.
Right. Now coming to next slide.
The environmental threat changes completely here, so the biological engineering must completely pivot.
Slide 10 is titled The Specialized Linings, Sulcular and Junctional. The text immediately presents a massive structural departure. Unlike the outer oral epithelium, these internal layers are non-keratinized.
So we are looking inside the moat now.
Yeah, and looking at the diagram, the tough, fibrous stratum corneum is completely missing, replaced by a softer surface layer, and the granular layer is absent as well.
This is the critical evolutionary pivot.
Because it's sheltered.
Exactly. The outer oral epithelium faces the friction of mastication, so it deploys a passive dead keratin shield. But inside the 2 to 3 millimeter sulcus, the moat, the physical friction of chewing is practically non-existent.
Right, the primary threat inside the moat is the bacterial biofilm.
Precisely. And a static, dead wall of keratin is a terrible defense against a bacterial biofilm.
Why is it terrible? It's tough, isn't it?
It's tough mechanically, but bacteria would simply adhere to the keratin, secrete proteolytic enzymes to dissolve the proteins, and slowly tunnel their way down toward the ligament.
Ah, so it's a sitting duck.
Exactly. To counter an active biological threat, the host requires an active immunological defense.
Okay, let me read the text box on the slide titled The Clear Cells. It reads, rather than an armor of dead keratin, these non-keratinized linings contain specialized biological actors, including melanocytes, Langerhans cells, Merkel cells, and lymphocytes.
Because the sulcular and junctional epithelia don't waste energy synthesizing mass quantities of keratin and don't undergo cornification, the tissue remains soft, viable, and metabolically active all the way to the surface.
Well, it's alive.
Yes. This creates a permeable environment that allows these clear cells, which are non-keratinocyte cells, to inhabit and patrol the epithelial layers.
Okay, let's break down this cellular army. I know Merkel cells act as highly sensitive mechanoreceptors, providing tactile feedback to the central nervous system, and melanocytes produce melanin pigment, though I have to push back here. Why would the body deploy pigment-producing melanocytes deep inside a hidden sulcus, where the sun literally never shines?
It's an excellent question, and it really shifts how we think about melanin. While melanocytes are famous for UV protection, melanin and its precursors actually possess potent antimicrobial and reactive oxygen scavenging properties.
Wait, really? Melanin fights bacteria?
In this context, yes. They act as a biochemical buffer against the massive oxidative stress produced by the inflammatory battle happening in the moat.
That is fascinating.
But the true heavy cavalry in this environment are the Langerhans cells and the lymphocytes.
How do they operate within the tissue?
Langerhans cells are highly specialized dendritic cells. They sit in the suprabasal layers of the epithelium, extending long, dendrite-like arms toward the surface. They are sentinels.
Like lookouts.
Exactly. They capture bacterial antigens that penetrate the superficial layers, process these foreign proteins, and physically migrate out of the epithelium, traveling to local lymph nodes to present the antigens to T cells.
Initiating a highly specific adaptive immune response.
Yes, exactly.
And the lymphocytes. The text mentions them too.
Lymphocytes, along with polymorphonuclear leukocytes, or PMNs, are the active soldiers. They receive the chemical signals, transmigrate from the central core, move through the epithelial layers, and enter the sulcus to physically phagocytose, to engulf and destroy the invading bacteria.
So by abandoning the keratin armor, the tissue transforms from a static brick wall into a permeable, actively patrolled immunological deployment zone.
That's a perfect summary.
But how exactly do these soldiers physically move through a solid wall of cells? Now coming to next slide.
This is where we examine the precise architectural modifications of the cellular matrix that make this movement possible.
Slide 11 provides the epithelium comparison matrix. It's a cross-reference grid comparing our 3 zones: oral, sulcular, and junctional.
Let's trace the engineering logic across these rows.
Okay, row 1, type. Oral is keratinized. Sulcular and junctional are non-keratinized. We just covered the necessity of that shift.
Correct. The transition from physical barrier to immunological gate.
Row 2, cell size. Oral and cellular are normal, but under junctional, which is the specialized attachment at the very base of the moat, it says larger relative to volume.
Right, so the cells of the junctional epithelium have a higher cytoplasmic volume relative to the number of desmosomes connecting them.
Meaning what exactly?
They are plumper, less densely packed cells. Keep reading, because the next row explains the mechanical consequence of this geometry.
Row 3, intercellular space. Oral is normal, cellular is normal. Under junctional, it reads wider.
There's the aha moment.
Let me highlight this because it seems entirely counterintuitive at first glance. The junctional epithelium is the absolute bottom of the pocket. It is the final seal preventing bacteria from invading the bone.
Right.
Why on earth would the body engineer the final, most critical seal with wider spaces between the cells? It sounds like an intentional structural weakness.
Yeah.
I mean, if you widen the gaps to let the immune cells out, don't you simultaneously create a massive highway for the bacteria to get in?
That is the fundamental paradox of the junctional epithelium, and it represents a absolutely brilliant fluid dynamic solution.
Fluid dynamics.
Yes. The intercellular spaces in the junctional epithelium are up to 4 times wider than in the oral epithelium, and the desmosomal junctions are far fewer. It is highly permeable.
But the bacteria don't flood in.
No, because of positive hydrostatic pressure.
Positive pressure, like water flowing out of a breached dam.
Exactly like that. The underlying vascular network in the central core is slightly hyperemic. It has a highly robust blood flow. This creates a hydrostatic pressure gradient that forces serum exudate, that gingival crevicular fluid we talked about, out of the capillaries through those deliberately widened intercellular spaces in the junctional epithelium and out into the moat.
Oh, wow. So it's a one-way street. The fluid is constantly rushing outward, physically washing the bacteria away from the deeper tissues.
It is, and it's not just water. That fluid is packed with antimicrobial peptides, defensins, and specific antibodies.
And the immune cells.
Yes, those wider intercellular spaces serve as physical highways for the PMNs, the neutrophils. They undergo diapedesis, literally squeezing out of the blood vessels and utilizing those wider gaps to swarm through the junctional epithelium in massive numbers.
Like an army marching through the gates.
Forming a living wall of white blood cells right at the base of the sulcus. The weakness of the wider spaces is exactly what allows the overwhelming deployment of the immune defense.
That is amazing. Which perfectly aligns with the final row of the matrix. Granular layer. Oral is present. Sulcular and junctional are absent.
Right, the junctional epithelium cannot afford to build keratin factories or secrete waterproofing lipids from Ardlan bodies.
Because that would plug the intercellular highways and block the outward flow of the immune arsenal.
Exactly. Every single variable in this matrix is a calculated bioengineering trade-off.
We really need to look at how all these systems overlap. Now coming to next slide.
We reach the grand unification of the atlas here.
Slide 12, the final slide. The title is Synthesis, a masterclass in biological engineering. The visual here is a composite overlay. It takes the macroscopic clinical photograph of the teeth and gums and precisely superimposes the microscopic line art schematics of the cellular layers directly over their corresponding geographic zones.
It really ties it all together beautifully.
You can see the dense layer cake on the outer anchor and the permeable, wider-spaced clear cells lining the invisible moat. Let me read the concluding text word for word. Synthesis, a masterclass in biological engineering. From the visible structural collar of the marginal gingiva to the invisible width of intercellular spaces in the junctional epithelium, every layer of the periodontium is precisely engineered. The macroscopic geography and microscopic biology work in perfect unison to lock the tooth into the jaw while repelling a relentless oral environment.
Masterclass is the only appropriate word for it. When we began this deep dive, we were looking at what appeared to be a mundane, monolithic pink tissue.
Just normal gums.
But by mapping the geography and descending the microscopic elevator, we have uncovered a system of breathtaking elegance and complexity.
Yeah, I mean, we started with the dense, multidirectional collagen hammock of the periodontal ligament, requiring the firm, periosteum-bound anchor of the attached gingiva to protect it from the violent shear forces of mastication.
Right, the mechanical support. And then we observed how the interduntal papillae and the hidden coal act as highly reactive architectural tents, dynamically molded by the mechanotransduction of the adjacent teeth, and how they physically collapse when that tension is removed.
And we tracked the immense metabolic cost of the keratinization elevator, watching basal cells execute a programmed sequence of cytodifferentiation manufacturing tenofibrils. secreting lipid seals, and ultimately undergoing cornification to form a hardened sacrificial shield.
And finally, we explored the immunological brilliance of the sulcular and junctional epithelia, a system that deliberately abandons keratinization and widens its intercellular spaces.
Sacrificing structural rigidity to create a highly permeable, hypervascularized deployment zone.
Utilizing hydrostatic pressure and an army of Langerhans cells, lymphocytes, and neutrophils to wage a continuous, lifelong, microscopic war against a constantly mutating bacterial biofilm.
The macroscopic form and the microscopic function are just inextricably linked. It's its intricate biological balancing act, navigating impossible contradictions. I mean, it's rigid, yet elastic, impenetrable, yet highly permeable, dead on the surface but vibrantly alive just millimeters below.
It is a dynamic equilibrium that functions silently and efficiently, 24 hours a day, adapting to every thermal shock and bacterial assault we subject it to.
And that brings us to the end of our 12-slide atlas. But before we conclude this deep dive, we must ground this advanced histology back into reality. Back to you, the listener.
Because this isn't just abstract cellular biology happening in a textbook.
No, this is the reality functioning inside your own head. The next time you stand at your bathroom sink holding a toothbrush or a piece of dental floss, I want you to look closely at your gum line. Look at the stippled anchor. Look at the collar. Look at the peaks between your teeth.
Recognize that you are not simply performing a cosmetic chore. You are directly intervening in a highly contested biological war zone.
Exactly. When you sweep that floss down into the hidden 2 to 3 millimeter sulcus, you are physically disrupting the bacterial biofilm, removing the microbial load so that your junctional epithelium doesn't have to widen its gaps further.
So that the inflammatory infiltrate doesn't escalate and trigger the destruction of the underlying bone.
You are providing essential mechanical support to a microscopic army.
I want to leave you with one final provocation, something that pushes beyond the boundaries of this atlas.
All right, what is it?
Well, we have repeatedly used the terminology of engineering today. In the fields of human bioengineering, advanced material science, and medical prosthetics, one of the greatest unsolved challenges is the creation of a permanent permucosal seal.
A permucosal seal.
Yes. How do we create a watertight, infection-proof seal between a rigid, non-biological structure, like a titanium implant, a transcutaneous catheter, or a prosthetic limb, and the soft, living tissue of the human body?
That's a huge problem. Our engineered seals inevitably fail over time. The materials degrade, the tissue retracts, and bacteria tunnel in.
Exactly. Even with our most advanced osseo-integrated dental implants, we cannot perfectly replicate the intricate, immune-patrolled, vascularized seal of the natural junctional epithelium. Human engineering relies on static barriers.
But the gingiva utilizes a dynamic, self-renewing, chemically active interface.
That modulates its own permeability based on the immediate microbial threat. If materials scientists and bioengineers can eventually decode and replicate the exact mechanotransduction pathways and chemoattractive signals that build the geography of the gingiva,
We could completely revolutionize implantable medical technology.
exactly. The blueprint for the ultimate biological seal is literally sitting right behind our lips.
That is a profound thought to end on. From the simple act of brushing your teeth to the future of bio-integrated prosthetics, the answers lie in understanding the microscopic geography. At the beginning of this deep dive, we talked about how comforting the binary, jagged line of a broken bone on an X-ray can be. But having explored the layered defenses, the active cellular elevators, and the immunological highways of the periodontium, I think the murky, dynamic world of soft tissue is infinitely more fascinating.
It's purposeful, it is remarkably resilient, and it is beautifully complex. You know, when you look in the mirror and smile, you probably just see your teeth.
Right, just teeth and maybe some pink tissue holding them in place.
Exactly. It looks totally simple, like it's just a static, quiet part of your body.
Yeah, it really does.
But if you were to zoom in, like really zoom in at a microscopic level, you wouldn't see simple pink tissue at all. You would see what is essentially a medieval fortress.
Oh, absolutely.
It's this heavily guarded, structurally complex biological castle that is constantly under siege.
It is the absolute definition of a biological battleground.
Yeah.
I mean, we tend to take it for granted, but the environment inside your mouth is incredibly hostile.
Yeah, I didn't even think about that.
Oh, it's brutal. It is constantly bombarded by massive, mechanical, crushing forces from chewing, extreme temperature swings from the food you eat, and literally billions of bacteria trying to breach the walls every single second.
So today, for you listening, we've got the blueprints to this exact biological fortress. We have a deck of 15 incredibly detailed masterclass slides, and we are going to take you layer by microscopic layer to see exactly how this structure survives.
It's going to be a fun one.
We're doing a complete structural deep dive into the microscopic anatomy of the gums, what our sources wonderfully call the periodontal fortress.
And it really is a masterpiece of architectural engineering.
Yeah.
Every single cell and microscopic fiber has a specific defensive or structural purpose. We aren't just looking at tissue, we are looking at armor, moats, drawbridges, and siege rigging.
Well, let's open those blueprints right now. Looking at slide 1, it's titled The Periodontal Fortress, and it introduces the 3 main structural components of this stronghold.
Right.
You've got the epithelium, which the slide labels the shield. Then beneath that is the connective tissue, which is the foundation.
Right.
And finally, you have the alveolar bone acting as the anchor.
Yep, those are the big 3.
But, why go through all this trouble? Why does the body need such an intense, multi-layered defense system just for our teeth?
Well, think about the anatomy of a tooth. The crown, the part you actually see when you smile, is covered in enamel.
And that's super hard, right?
Exactly.
Yeah.
The hardest substance in the human body. It can take a beating. But the root of the tooth, which anchors down into your jawbones, is highly vulnerable.
Oh, I see.
If that hostile, bacteria-filled environment of the mouth breaches the gum line and gets down to the root, the whole system collapses. The bone gets infected, and the tooth literally falls out.
Mm-hmm.
This entire fortress exists solely to protect that one vulnerable root.
Wow.
Yeah.
Okay, that makes sense. Now coming to next slide.
So slide 2 maps out the specific anatomy of the gingiva, which is just the medical term for the gums. We're looking at 4 distinct zones here.
Right, and let's map these out for you using our castle metaphor. First, you have the oral epithelium. This covers the crest and the outer surface of the gums. That's your tough outer brick wall facing the main courtyard of the mouth. Then, dipping down inside the little pocket right next to the tooth, you have the oral sulcular epithelium.
You can think of that as the inner moat wall.
Exactly, the inner moat wall. At the very base of that moat is the junctional epithelium. That forms the actual seal, almost like a drawbridge locking flush against the castle tower.
That's a great way to picture it.
And then underneath all of this is the supraalveolar connective tissue. That's the dirt foundation supporting the entire structure above it.
Which highlights a really great point. Just like a real castle, the outer walls that are taking the brunt of the attack are built very differently from the inner mechanisms hiding inside the moat.
That's fascinating. Now coming to next slide.
Which brings us to slide 3, the oral epithelium.
The outer shield.
Right. This is that outer keratinized shield. And if we look closely at the cytology, it is actually built of 4 distinct cellular layers. At the very bottom, attached to a basement membrane, is the stratum basal.
And what happens there?
This is a layer of cylindrical or cuboidal cells where active cell division happens. It's basically the birthplace.
Okay, so the cells are born at the bottom. What happens as they move up?
They enter the stratum spinosum. These are large cells that develop these short cytoplasmic spines, which kind of gives them a prickled appearance.
Oh, weird, like little spikes.
Yeah, exactly. And they use these spines to connect to each other with numerous desmosomes.
And desmosomes are basically like microscopic spot welds holding the cells together, right?
Precisely. They provide serious tensile strength. Then moving up again, we hit the stratum granulosum, which contains these electron-dense keratohyaline bodies.
Keratohyaline bodies, got it.
Right, and this is where the cell starts actively manufacturing keratin, which is a tough, fibrous protein. Finally, the top layer facing the mouth is the stratum corneum.
And that's the part we can actually see.
Exactly. Here, the cells are filled entirely with keratin and have completely lost their nuclei. They're essentially dead, hardened shields at this point.
I want to pause on the clinical distribution note on this slide, actually. It says the palate, like the roof of the mouth, is the most heavily keratinized tissue.
Yes.
The gingiva is moderately keratized, but the underside of the tongue and the cheeks are the least. Why is the roof of the mouth armored so much more heavily than the cheeks?
It's a brilliant evolutionary response to mechanical friction. Think about it. When you chew, food is constantly being crushed and dragged against the roof of your mouth.
Oh, right, like eating Captain Crunch or something.
Exactly. The tissue there needs a super thick, hardened keratin shield, so it doesn't just tear under the sheer force of a crunchy chip. Your cheeks, however, they need to stretch. They have to be flexible to manipulate the food while you chew.
Ah, so it's a trade-off.
Yep. The body strategically sacrifices that heavy armor on the cheeks in exchange for mobility.
That is so smart. Now coming to next slide.
Slide 4 illustrates the timeline of this whole process. It's titled, The 30-Day Journey of a Single Keratinocyte.
I really love the visual the source uses here. It's described as an escalator of maturation.
It's a perfect analogy.
So on day 1, our little cell is born down in the stratum basal. It divides, and the older cell gets pushed upward onto the escalator. Then, roughly between days 10 to 20, it goes through differentiation in those middle layers.
Right, it's building up its defenses.
Exactly.
Yeah.
It's massively multiplying its spot welds, the desmosomes, and building internal tonofilaments for structural integrity. But at the same time, its internal organs, the mitochondria, rough endoplasmic reticulum, and Golgi apparatus, they're all degrading. Finally, around day 30, it reaches the surface at the stratum corneum and undergoes desquamation, meaning it basically sheds off into the mouth.
And this raises a point that is so often misunderstood in biology. That process during days 10 to 20, when the cell is losing its mitochondria and its nucleus, that is not degeneration. It sounds like the cell is just slowly dying, but these cells are actively, purposefully transforming themselves.
Oh, wow.
They are orchestrating their own biological sacrifice to become hardened, interlocking plates of armor before they finally flake off.
That's incredible. Now coming to next slide.
On slide 5, we shift from that tough outer wall to the inner moat, the oral sulcular epithelium.
So this is the soft tissue wall lining the little pocket right up against the tooth. Structurally, it extends from the gingival margin down to the junctional epithelium.
Right.
But unlike our outer wall with its 4 layers, this inner moat only has 2 layers, the basal and the prickle cell layers. It doesn't have that heavy keratin armor. Why leave the moat unarmored?
Well, because nothing's really chewing on it. Food shouldn't be getting down into that narrow pocket normally, so the body doesn't need to waste resources building a heavy friction shield there.
That makes sense.
However, the most crucial detail on this slide is actually a diagnostic one. Normally, this sulcular area has no reet pegs.
Reet pegs being those interlocking ridges that dip down into the connective tissue.
Exactly. In a healthy sulcular epithelium, that boundary is completely flat. But if a dentist looks at a biopsy of this tissue and sees reet pegs forming, it is a massive red flag.
Wait, really? Why?
It means the tissue is mounting an inflammatory response to disease. The bacteria are winning, they're getting into the moat, and the wall is desperately trying to reinforce itself by building those pegs.
Oh, that's wild. Now come into next slide.
Slide 6 takes us to the very bottom of the pocket, the junctional epithelium. This is the biological seal at the base of the moat.
And the dimensions here are just incredibly tiny. The length of this entire seal is just 0.25 to 1.35 millimeters.
It's microscopic.
And at the top, it's about 15 to 20 cell layers thick. But as it tapers down to the very base, it thins out to just 1 to 2 cell layers. And wait, looking at the notes here, this is supposed to be the main defensive drawbridge locking against the tooth, right?
Yes, that is its primary role, to seal it off.
Then why does the slide say it is highly permeable? It has fewer desmosome spot welds and really wide intercellular spaces. That sounds like a terrible leaky seal. Why would you want your main defensive checkpoint to be leaky?
Because a solid brick wall can't fight back. That permeability is completely intentional. It allows for a constant defensive patrol. Because the cell junctions are wide, leukocytes and lymphocytes, which are your body's white blood cells, can actually slip through the tissue.
So they're patrolling the borders.
Exactly. They constantly sweep the area for invading bacteria. Furthermore, the cells near the base actually have phagocytic capacity. They can act like little Pac-Man, actively engulfing and consuming microscopic debris. It's not a passive wall at all. It's an actively guarded, dynamic checkpoint.
That is so cool. Now coming to next slide.
Slide 7 zooms in even closer, looking at the microarchitecture of epithelial attachment. Basically, how does flesh actually stick to the slippery stone of a tooth?
Right, because enamel doesn't have pores for the tissue to grow into. The slide notes that researchers Schroeder and Listgarten discovered that the tissue maintains actual structural continuity with the tooth. It's not just pressed tightly against it.
Nope. It achieves this through a highly specialized interface. The cells produce an internal basal lamina. Think of this as the microscopic mortar.
Okay, mortar.
It's split into 2 zones. You have the lamina densa, which is situated directly adjacent to the tooth enamel, and the lamina lucida, adjacent to the epithelial cells.
But mortar isn't enough on its own, is it?
No, it's not. To lock it together, the cells use structures called hemidesmosomes. These are electron-dense zones that physically bridge the cell's internal skeleton to the basal lamina. They act exactly like biological rivets, locking the entire seal permanently onto the side of the tooth.
Wow, biological rivets. Now coming to next slide.
Slide 8 provides a recap chart, giving us a really nice functional synthesis of the three epithelia we've just toured.
Okay, let me see if I've got the logic down for you guys listening. The oral epithelium is the outer armor. It has 4 distinct layers, prominent reed pegs for stability, heavy keratin, and low permeability. Its job is to survive the crushing friction of potato chips. Then, the oral sulcular epithelium is the moat lining. Only 2 layers, unkeratinized, moderate permeability, and a flat border with no reed pegs unless it's infected. Finally, the junctional epithelium is the active checkpoint. It tapers from 20 layers down to 1, completely non-keratinized, and has very high permeability to let the immune system patrol and attach to the tooth.
Spot on. When you see them side by side like that, you realize the tissue isn't just one monolithic thing. It is beautifully specialized, millimeter by millimeter, based on exactly what kind of attack it's facing.
It really is. Now coming to next slide.
Slide 9 looks beneath the surface at the interlocking interface of epithelium and connective tissue. We mentioned reed pegs earlier. This shows how they actually work.
The visual here is great for the imagination. If you picture 2 egg cartons pressed together, that's exactly what this boundary looks like. The reed pegs project deeply downward from the outer epithelium, and the connective tissue papillae push upward to meet them.
And the mechanical purpose of that egg carton shape is massive. By undulating the border, you exponentially increase the surface area.
Which means what, practically?
It means more room for blood vessels to nourish the outer layers and incredible mechanical stability. If you drag food across the gums, the outer layer won't just slide off because it's locked into those deep ridges. And holding those ridges together are anchoring fibrils. These are tiny 20 to 40 nanometer thick threads that splay out like fans, physically binding the complex of the epithelium, the lamina lucida, and the lamina densa to the connective tissue below.
That is some heavy-duty engineering. Now coming to next slide.
We finally step down past the walls into the foundation on slide 10, the lamina propria.
This is the connective tissue, and the blueprints show it split into 2 layers. Right under the epithelium is the superficial papillary layer.
Right.
This area wraps into those egg carton ridges we just talked about. It has loosely arranged collagen and abundant capillary loops. Below that is the deeper reticular layer, and reticular essentially means net-like, right?
Exactly. This deep layer sits between the papillary layer and the underlying jawbone. It is completely dominated by thick, net-like bundles of type I collagen. If the top layer is all about supplying blood, this deeper layer provides the bulk tensile strength of your gums.
The slide also lists the cells living down here. Macrophages, mast cells. But the real stars seem to be the fibroblasts. I shouldn't just think of them as floating cells, right? They're more like the castle masons.
That's the perfect way to look at them. Fibroblasts are the primary fiber producers. They're constantly spinning new structural threads, collagen type I and II, reticulin, elastin. They're repairing the microtears that happen every single time you eat.
So they're always working. Now coming to the next slide.
Slide 11 brings us to ground substance, which the slide brilliantly titles the biological shock absorber.
Because all those collagen cables and fibroblasts aren't just floating in empty air, they are suspended in this matrix of glycoproteins and proteoglycans, things like chondroitin sulfate and hyaluronic acid.
Yes, exactly.
It acts as a molecular filter for nutrients, but mechanically, this is wild. It acts exactly like a water-filled memory foam mattress.
It really does. Think about the physics of a bite. You can exert hundreds of pounds of force when you chew.
Right.
If your gums were totally rigid, that force would literally crush the cells. Instead, when you bite down, the chewing forces compress the gingiva. The ground substance absorbs the load and expels its water content.
Like squeezing a sponge.
Exactly. And the moment you open your jaw and the force is eliminated, the matrix rapidly recoils, sucks the water back in, and instantly regains its shape.
That is so elegant. Now coming to next slide.
Slide 12 maps out the heavy lifting. The principal gingival fibers, these are the main rigging cables holding the entire fortress to the anchor.
If the tooth is a giant stone tower, these are the massive siege ropes ensuring it doesn't tip over. There are 5 main fiber groups. You have the dentogingival fibers projecting in a fan shape from the tooth cementum up into the gums, the alveolar gingival fibers extending from the bone periosteum up into the lamina propria.
And my personal favorite, the transeptal fibers.
Why are those your favorite?
Because they extend straight across from the root of one tooth directly into the root of its neighbor. They literally tie the towers together so they share the load of a heavy bite.
Oh, teamwork. I love that.
Exactly. You also have the dentoperiosteal fibers arching over the bone crest, and the circular fibers, which are basically biological iron bands that wrap entirely around the tooth in a cuff-like fashion to pull the gums tight against the enamel.
Unbelievable. Now come into next slide.
Slide 13 details the secondary gingival fibers. If the principal fibers hold the individual tower down, these secondary cables maintain the alignment of the entire castle wall.
Okay, looking at this slide, there is an intimidating list of 6 different secondary fiber groups. Periosteogingival, interpapillary, transgingival, intercircular, intergingival, and semicircular.
It's quite a mouthful.
Yeah, I'll be honest, I am not going to remember all of these names. What is their actual collective job?
Don't get bogged down in the Latin prefixes. Group them together functionally. Think of them as a complex chain-link fence weaving through the gums.
Okay, a fence.
Some wrap around the back of one tooth and the front of the next. Some run in long, straight lines across the entire arch of your mouth. Their collective job is to keep your teeth from drifting apart and to keep the gum tissue tightly contoured around the entire row of teeth.
That makes a lot more sense. But hold on, I have a question about this little footnote here. It mentions elastin fibers are present in the gingiva and PDL, but then it specifically highlights oxytalin fibers. What are those?
That is one of those fascinating, ongoing mysteries in dental histology.
A mystery.
Yes. Oxytalin fibers exist completely throughout this structural network. We can easily see them under an electron microscope. But their function, it remains entirely unknown to modern science.
Wait, really? We just don't know.
We know they're woven into the fortress. We just don't know exactly what they're doing yet.
That's crazy. They're coming in next slide.
Slide 14 reveals the infrastructure keeping this whole fortress alive and functioning. The blood supply, lymphatics, and nerves.
Well, you can't run a fortress without supply lines. The blood comes from 3 major routes: supraperiosteal arterioles running along the outside of the bone, vessels from the periodontal ligament flowing upward, and arterioles emerging directly from the crest of the interdental bone itself. Why, 3 different routes just for the gums?
Redundancy.
Ah.
A fortress under siege needs backup supply lines. If a massive piece of food is pressing hard against the side of your gums, cutting off the surface blood flow, the tissue doesn't die.
It just switches routes.
Exactly. It just pulls oxygen from the secondary vessels coming up from the bone or the ligament. It's a failsafe. And where there's blood flow, there must be drainage. The lymphatic vessels drain the waste away to your regional nodes, mainly the submaxillary. Meanwhile, the nerves derive from periodontal ligament fibers and provide the sensory feedback so you know exactly how hard you are biting.
Everything is connected. Now coming to next slide.
Which brings us to our final blueprint, slide 15. Synthesis, the dentogingival unit.
This is where the whole tour comes together. The functional dentogingival unit is the ultimate collaboration of everything we've talked about. You have the leaky defensive drawbridge of the junctional epithelium pressed up against the tooth, but it's mechanically reinforced and held tight by the massive tension of those gingival fibers we just discussed.
Exactly. Together, they achieve the core protective functions of the fortress. They brace the marginal gingiva firmly against the enamel. They withstand the immense hydraulic and mechanical forces of mastication chewing. And they firmly unite the free tissue to the root cementum to maintain the entire periodontal fortress.
Right.
If any one of these systems fails, if the fibroblasts stop building collagen or the immune cells stop patrolling the permeable seal, the integrity of the entire periodontal fortress collapses.
And just like that, we can close the blueprints. You made it through all 15 structural maps. It's truly wild to think that the simple, mindless act of chewing a piece of food relies on this incredibly dynamic, interlocking fortress of dividing cells, shock absorbers, and biological rigging that is constantly renewing itself.
It really is awe-inspiring. And as we zoom back out, I want to leave you with a provocative thought to mull over.
Go for it.
Consider that 30-day journey of the keratinocyte cell on its escalator of maturation. Our gums are constantly, seamlessly rebuilding this complex barrier while under the crushing hostile forces of daily chewing, never leaving a single gap in the armor.
Yeah.
What secrets might this specific tissue hold for the future of medicine? If we can fully unlock how the periodontal fortress regenerates and heals itself under such extreme duress, it could completely revolutionize wound healing and regenerative therapies for the rest of the human body.
Man, from a tiny biological seal to the future of regenerative medicine, it really makes you realize the next time you look in the mirror and smile, you aren't just looking at gums, you're looking at a masterpiece of survival. I want you to imagine something, like for just a second. You are absolutely starving, right?
Okay, I've been there.
You grab a handful of trail mix and you just chomp down as hard as you can on a completely solid, unyielding almond.
Oh,
Think about the sheer mechanical force your jaw just generated. I mean, the human bite can exert hundreds of pounds of pressure per square inch.
it's massive, yeah.
So why didn't your teeth just shatter into a million pieces? Or, even more terrifying, why didn't that intense pressure drive the rigid root of your tooth straight up into your skull bone?
Yeah, that is a slightly horrifying mental image.
Right, right.
But it sets up the exact physical paradox we're looking at today. Because mechanically speaking, if you take two highly mineralized, rigid structures like a tooth and a dang bone and grind them directly against each other with that much force, it should result in immediate structural failure.
They should just crack.
Exactly. You would expect microfractures at best or, catastrophic bone crushing at worst.
Exactly. But that doesn't happen. And today, we are going on a very special mission to find out why. We are decoding this really fascinating presentation we got.
Yeah, 15 slides of pure biological engineering.
Literally a microscopic miracle happening inside your head right now. Okay, let's unpack this. The secret to your teeth surviving your lunch entirely comes down to something called the periodontal ligament, or the PDL.
Right. And for a long time, early anatomists, they just thought of the PDL as biological glue.
Just some paste holding things together?
Pretty much. They assumed it was just inert, sticky connective tissue cementing your teeth into your jaw. But as the research in these sources clearly shows, it is so much more than that. It's a highly dynamic, living suspension system that is constantly remodeling itself.
Which is a really beautiful way to frame it. And to see exactly how this tissue bridges the gap between tooth and bone, let's dive right into our source material. Now coming to the next slide.
So this slide establishes the foundational identity of the periodontal ligament. It defines the PDL as a highly dynamic, soft connective tissue.
Right.
And its main job is providing continuity between those two heavily mineralized structures we just mentioned, the cementum on the root of your tooth and the alveolar bone of your jaw.
I really love the visual the presentation uses here, calling it a living suspension bridge.
Yeah, it's a great metaphor.
Because if you picture a massive suspension bridge, the heavy road deck isn't resting on solid pillars underneath it. It's suspended in the air by, highly engineered tension-bearing cables.
Absolutely.
Or better yet, imagine a bungee jumper suspended in a massive canyon between two solid rock cliffs. The tooth is the jumper, the bone is the cliff, and the PDL is this complex array of bungee cords holding everything in perfect bouncing equilibrium.
And that bouncing equilibrium is exactly what keeps the tooth from acting like a nail being hammered into a piece of wood. It distributes the load.
To see just how incredibly tight that canyon actually is, let's look at the physical measurements. Now coming to the next slide.
So this slide zooms in on the physical dimensions. And this is where the sheer scale of this biological engineering gets wildly impressive. We are talking about an hourglass-shaped gap that averages just 0.25 millimeters wide.
Wait, 0.25 millimeters? That is literally a fraction of a millimeter.
It's tiny. Historically, scientists have called it a few different things, the desmodont, gomphosis, pericementum, but whatever term you prefer, the specific geometry of this tiny space is what's critical.
Because of the hourglass shape.
Yeah, the geometry is absolutely the key to the physics here. The fact that it's hourglass-shaped means the gap is slightly wider at the top, near the crest of your gums, and wider at the bottom, down near the apex of the root.
Okay.
But in the middle of the root, the space narrows, and that narrowest point acts as a structural fulcrum.
So mechanically, it functions exactly like the pivot point in the dead center of a seesaw.
Precisely. Because it has that tight pivot point in the middle and wider spaces at the upper and lower ends, the tooth actually has room for physiological movement. It isn't locked in place.
Oh, so it can tip and tilt.
Exactly. It can absorb angled impacts without tearing right out of the socket. The slide also notes that this tiny gap maintains continuous communication with the bone marrow spaces through microscopic channels in the bone called Volkmann's canals.
We'll see how crucial those are for fluid dynamics in a bit. But a microscopic seesaw built into every single tooth to handle angled chewing forces is just wild.
It really is.
Which makes you wonder how the body builds that mechanism. Let's look at the anatomical overview. Now coming to the next slide.
Here we get an overview of the anatomy of this dynamic joint. The PDL is supported by four main pillars.
Okay, let's list them out.
First, you have the architecture, which consists of the collagen cables themselves. Second, you have the workforce, which are the specialized cells building and maintaining those cables.
Right.
Third is supply lines, meaning the complex network of blood and lymphatic vessels. And finally, the wiring, which refers to the highly sensitive trigeminal mechanoreceptors.
Wait, let me stop you right there. I have to push back on the logistics of this.
No, for
You're telling me that all four of these massive, distinct biological systems, structural cables, active cellular manufacturing factories, a plumbing system of blood vessels, and a complex neurological wiring grid are all crammed together into a gap that is 0.25 millimeters wide.
Yo.
How do they not just constantly tangle up or crush each other every time you bite down?
I know, it sounds literally impossible, but it is a marvel of spatial efficiency. They don't crush each other because everything is highly compartmentalized and it's suspended in a pressurized fluid environment.
Ah, okay.
The architecture provides a very specific structural scaffolding, and the other three systems weave themselves safely through the protected spaces within that scaffold.
Which makes perfect sense when you see the actual layout of those cables. Let's trace that map, now coming to the next slide.
So this slide provides the map of the structural cables, which are primarily composed of high molecular weight type I collagen. These are called the principal fibers. And they aren't just thrown in there randomly. They are organized into very specific directional groups to handle entirely different vectors of force.
Right, looking at the map, you have several distinct groups here. There's the transeptal group connecting tooth to tooth over the bone crest to keep your entire dental arch tightly aligned. You have the horizontal group, which resists lateral side-to-side pushes. The interradicular fibers, which only exist in teeth with multiple branching roots, specifically to stop twisting motions.
Right, and the alveolocrestal group to keep the tooth from being pulled outward.
And the apical group sits at the very bottom to protect the delicate nerve supply from being crushed. But the presentation highlights the oblique group as the absolute star of the show.
Oh, the oblique group is functionally brilliant. It is by far the largest fiber group in the PDO, and it runs diagonally upward from the tooth root to the bone.
Okay, so it points up.
Exactly. And because of that upward diagonal angle, when you bite down hard, like on that almond, the downward pressure on the tooth actually pulls these diagonal cables taut.
Oh, wow.
It converts an immense, crushing compressive force into a pulling, tensional force on the bone.
So it essentially turns a hammer strike into a hammock swing.
That is exactly the mechanical translation. And it's vital because human bone is incredibly resilient under tension when it's being pulled, but it is highly susceptible to resorbing or failing under direct compression.
So the oblique fibers perfectly translate the force into a language the bone can handle.
Precisely.
But those cables can't just be rubbing against each other in dry air, or they'd snap from the friction. Let's look at what surrounds them, now coming to the next slide.
Now we examine the hydraulic environment. The microscopic space between all those collagen cables is filled with something called ground substance, backed up by a secondary support network.
The ground substance acts as the primary shock fluid, right? The presentation notes it's 70% water, packed with glycosaminoglycans, specifically hyaluronic acid, along with proteoglycans and glycoproteins.
Yes.
If we look at that through a mechanical lens, it's essentially a series of microscopic, water-filled airbags surrounding our bungee cords.
That hydraulic mechanism is absolutely crucial. Because water is largely incompressible, that fluid matrix provides instant hydrostatic resistance the millisecond force is applied.
Wow.
But within that fluid airbag, you also have secondary fibers acting as a specialized elastic web. You have oxytalin and elanin, which the source notes are immature forms of elastin.
Think of those like the elastic waistband in your sweatpants. They give the tissue elastic memory.
Exactly.
After that heavy bite stretches everything out, the oxytalin and elanin ensure the ligament snaps perfectly back into its original shape.
Precisely. And alongside those, you have fine lattice-like type 3 collagen called reticulate fibers and an indifferent fiber plexus that runs in all directions to hold the entire fluid and fiber matrix together in one cohesive unit.
It's an incredibly elaborate setup. So how does the body actually forge this connection in the first place?
Right.
Let's track the development timeline. Now coming to the next slide.
So this slide outlines the maturation process. Building this suspension bridge is uniquely difficult because it has to happen while the tooth is actively erupting into your mouth.
Right, it's a moving target.
Exactly. The slide breaks it down into 3 phases. Phase 1 is emergence. As the tooth first pushes up, fine brush-like fibrils start projecting outward from the root into that empty space. Simultaneously, thin, sparse fibers start appearing on the opposing bone wall.
Then we hit phase 2, elongation. Those fibers on the bone side start to thicken, multiply, and actively reach out toward the loose connective tissue in the center of the gap.
Which leads to phase 3, splicing. The fibers extending from the moving tooth and the fibers extending from the stationary bone meet right in the middle, intertwine, and fuse together into continuous, unified bundles.
It's like building a bridge from both sides of a river, except one side of the river is actively moving upward while you're trying to bolt the steel together.
It's crazy.
The sheer biological coordination required to do that successfully is staggering. To see exactly who is doing that construction work, let's meet the cells. Now coming to the next slide.
Here we meet the cellular workforce responsible for all this construction.
Yeah.
You have two distinct teams, the builders and the recyclers.
Okay.
On the building side, we have synthetic cells. Osteoblasts build the alveolar bone, and cementoblasts continuously deposit root cementum.
But on the flip side, you need demolition crews, because if you're going to remodel the bridge, you have to make room for new growth. Those are the resorptive cells. Osteoclasts are these large multinucleated cells that use a highly specialized ruffled border to grip onto bone and dissolve it. And cementoclasts, which live in little microscopic caves called house ships lacunae, are deployed to resorb the cementum during severe stress events.
Exactly. But then at the very bottom of the slide, the fibroblasts are highlighted in a unique blue box. They are listed as dual action.
Yeah, that dual capability is fascinating.
The fibroblasts are the true master controllers here. They synthesize new connective matrix, but they also have the ability to phagocytose, or consume and break down the old collagen to remodel it.
How does one single type of cell know when it's time to be a builder, pouring new collagen, versus when it's time to act like a demolition crew, eating up the old stuff?
It's incredible.
They are simultaneously wielding a cement mixer and a sledgehammer, switching between them flawlessly based on the mechanical load. To see how they actually manufacture this material, we need to zoom in. Now coming to the next slide.
This slide profiles the periodontal fibroblast in detail. It accounts for a massive 65% of the total cell population in the PDL.
Wow, 65%.
Yeah, they are stellate, meaning star-shaped, and structurally, the source notes they are absolutely packed with rough endoplasmic reticulum and Golgi apparatus.
Because they have such an extreme concentration of those specific organelles, you know they are acting as absolute manufacturing powerhouses.
Exactly.
The presentation actually maps out their workflow. First, the fibroblast releases tropocollagen, which consists of 3 intertwined polypeptide chains forming a helix. Those aggregate longitudinally to form protofibrils. Then they arrange laterally to become collagen fibrils. And finally, those bundle together into the massive principal fibers that anchor the tooth.
If we connect this to the bigger picture, it reveals a profound truth about the PDL. It is never static. Because you're constantly chewing, talking, and grinding, those principal cables are constantly experiencing micro-tears. If left alone, the bridge would eventually fail. So these fibroblasts run a relentless 24/7 manufacturing and recycling plant, constantly replacing the old, damaged collagen with fresh tropocollagen so the structural integrity never drops.
It's the biological equivalent of replacing the heavy steel cables on the Golden Gate Bridge, one microscopic wire at a time, without ever shutting down traffic.
That's spot on.
But fibroblasts aren't the only residents in this gap. Let's look at the quirkier neighbors, now coming to the next slide.
Right, the PDL is a complex ecosystem. This slide covers the remnants, responders, and anomalies that also occupy this tiny space. First, we have the epithelial rests of molasses.
Which have always fascinated me. They are essentially leftover dormant cellular networks from when the tooth root was first forming.
Exactly. They're remnants of Hertwig's epithelial root sheath. Clinically, they usually just sit there harmlessly for your entire life. But under pathologic conditions like severe localized inflammation, these dormant cells can rapidly proliferate and turn into massive jaw cysts or tumors.
So functionally, they are like abandoned construction equipment left buried underground from when the city was first built.
Oh, I like that.
Usually harmless, but if a water main breaks and floods the area with inflammation, that old equipment gets triggered and causes massive structural complications.
Yes, exactly.
Then you have the immune responders acting as the city's security detail. You have macrophages constantly patrolling the fluid for cellular debris, and mast cells, which are packed with heparin and histamine, ready to degranulate and trigger an intense inflammatory response the second they detect an invader.
And finally, you have cementicles, which are just strange, free-floating calcified masses sitting in the tissue. It's a very crowded neighborhood.
To see how a neighborhood this dense gets its nutrients, let's look at the plumbing. Now coming to the next slide.
Here we map out the hydraulic supply lines. A massive, highly active suspension system needs constant fuel. The blood supply comes from three main arterial routes. The dental artery feeds the deep PDL and the internal tooth pulp. The interdental artery emerges from the crest of the bone to feed the top region.
But the most mechanically interesting one is the interradicular artery. The bone surrounding the root isn't completely solid. It's called the cribriform plate because it looks like a sieve full of microscopic holes.
Right.
The interradicular artery literally pierces horizontally through those holes in the bone to feed the PDL directly from the sides. But let me ask you this. If the cribriform plate is full of holes just to let these arteries through, aren't we perforating the exact bone that needs to be strongest to absorb the force of the bite? That seems structurally counterintuitive.
It would be counterintuitive if it were just dry bone. But these arteries aren't just a catering service bringing food and oxygen.
Right.
Because they are constantly pumping pressurized fluid into that 0.25 millimeter space, they are actively creating the hydrostatic pressure that allows the PDL to function as an incompressible airbag. The fluid flowing through those holes is a core component of the shock absorption.
The slide also notes the lymphatic vessels follow these exact same pathways backward to provide continuous drainage. So the plumbing is structural.
Right.
Brilliant. Now we need the electricity. Now coming to the next slide.
This slide covers the sensory wiring, referred to here as trigeminal telemetry. The PDL is richly supplied by mechanoreceptors directly connected to the trigeminal ganglion.
And the diversity of sensors is incredible.
Yeah.
You have free nerve endings distributed throughout the ligament that transmit pure pain. In the midroot region, you have Meissner's corpuscles handling fine touch.
Down at the apical area, Ruffini-like receptors are specifically calibrated to measure physical stretch. And finally, spindle-like endings at the apex detect deep pressure and high-frequency vibration.
This rich sensory network is why your teeth are so incredibly perceptive. They are not inert rocks.
Not at all.
Which explains so much about our daily life. This has to be the exact reason why you can be chewing a huge, complex, multi-textured bite of salad, and if there is one single microscopic grain of sand hidden inside a spinach leaf, your jaw instantly senses the abnormal vibration and stops chewing.
Yes. When that grain of sand hits, those spindle endings detect the high-frequency crunch. The Ruffini receptors feel the sudden stretch. And this telemetry sends positional data to your brain faster than you can even consciously process it.
The proprioceptive feedback loop is near instantaneous.
And that sensory input directly dictates how the physical forces are managed, which is an excellent segue into the mechanics of that force.
For sure. Now coming to the next slide.
This slide presents two competing scientific theories on exactly how this entire system achieves shock absorption, the tensional theory and the viscoelastic theory.
The tensional theory is the more straightforward mechanical model, right?
Yeah, it posits that the primary actors are the collagen fibers themselves. When force is applied, the wavy principal fibers unfold, pull taut, and transmit that force as pure tension to the alveolar bone.
Causing the bone itself to elastically deform and bend just a little bit to absorb the impact?
Exactly. But the viscoelastic theory focuses entirely on the fluid dynamics. It suggests the tooth acts exactly like a piston in an engine. When you bite down, the tooth pushes into the socket and violently squeezes the extracellular fluid out of the PDL, forcing it through those tiny holes in the cribriform plate we just talked about, directly into the bone marrow spaces.
And only after that fluid is depleted do the structural fibers finally tighten. Then, when the bite releases, the blood vessels balloon back up to quickly replenish the tissue fluid.
What's fascinating about scientific discourse at this microscopic level is that these theories aren't necessarily mutually exclusive.
They likely represent different sequential phases of the exact same millisecond event, right? Researchers are just trying to model incredibly fast, complex physical realities.
Precisely.
And the presentation actually synthesizes these ideas beautifully in the next section. Let's look at the full sequence. Now coming to the next slide.
This slide integrates all the pillars into the master system in action. It breaks down a heavy bite into a precise, 6-step chronological event.
Okay, let's walk through it.
Step 1. Impact hits the crown of the tooth. Step 2. Because of the hourglass shape and the fulcrum we discussed earlier, the tooth naturally rotates slightly around its structural axis to find the best angle of resistance.
Step 3. Hydraulic displacement. As it rotates, the fluid is instantly forced through the cribriform plate into the bone marrow, acting exactly like that viscoelastic piston.
Right.
Step 4. Tension. As the fluid vacates and the tooth tips, Those massive oblique fibers stretch taut on the opposite side, grabbing onto the bone and changing compression into tension.
Step 5 is telemetry. Right as that stretch happens, the spindle and Ruffini nerve endings fire proprioceptive data straight to your brain, instantly modulating how hard your jaw muscles are allowed to continue clenching.
And finally, step 6, cellular response. The tension on the bone physically stimulates the osteoblasts to wake up and build more bone to reinforce the area against future stress.
It's brilliant.
It's essentially a smart shock absorber that instantly messages the car engine in your brain to ease off the gas pedal before the chassis breaks, while simultaneously telling the cellular mechanics to reinforce the metal frame.
It is a perfect biological feedback loop.
Hmm.
But what happens when we manipulate that loop intentionally? Let's look at the clinical applications.
Absolutely. Now coming to the next slide.
Now we apply this to clinical reality, moving solid teeth through solid bone, otherwise known as orthodontics.
When you get braces, the wires do not mechanically force teeth through your jawbone. If you applied raw mechanical force, the rigid tooth would simply shatter the bone and fall out.
Right.
Orthodontics relies entirely on hacking the biological remodeling capacity of the PDL.
The slide clearly maps this out. When an orthodontic brace pulls a tooth in a specific direction, it creates two distinct environments in the PDL space. The trailing side is the tension side.
Okay.
The fibers stretch, which, as we just learned in step 6, triggers the osteoblasts to wake up and start filling in the widening gap with new bone behind the moving tooth.
And on the leaving side, the pressure side, the PDL is being compressed. This localized pressure triggers the osteoclasts, the demolition crew with the ruffled borders, to activate and dissolve the bone directly in the path of the moving tooth, clearing the way.
You are gently tricking the cellular workforce into remodeling the jawbone for you.
But the presentation includes a massive warning box here regarding force.
Yes. If an orthodontist applies forces that are too large or too fast, it bypasses this delicate cellular communication entirely. You end up pinching off those vital intraradicular blood vessels, cutting off the oxygen supply and causing necrosis or actual localized cell death of the PDL tissue.
Wow.
The remodeling system completely halts. You can only move teeth if you respect the biological limits of the ligament.
Which perfectly sets up what happens when things naturally go wrong. Let's look at the consequences of failure. Now coming to the next slide.
This final slide covers clinical limits, trauma, disease, and irreversibility. It breaks down two major scenarios where the system is overwhelmed.
The first scenario is acute trauma. This could be an accidental physical blow to the face or extreme unconscious teeth grinding at night.
Right.
This sudden trauma causes physical tearing of the principal fibers and artificially widens the PDL space, leading to a tooth that feels clinically loose in the socket. But the source notes the prognosis here is actually hopeful. It is usually reversible.
Yes, once the acute trauma stops, those dual-action fibroblasts go into absolute overdrive, manufacturing fresh tropocollagen to repair the torn cables.
The second scenario, however, is uncontrolled disease, specifically untreated gingival inflammation that creeps downward from the gums into the deeper periodontal structures.
And this causes systematic toxic destruction of the principal fibers in the alveolar bone itself.
And the prognosis there is notoriously irreversible. It is a very sobering reality check on why basic daily dental hygiene really matters.
Yeah, absolutely.
Once bacterial inflammation destroys the architectural masterpiece, we just spent 15 slides exploring the collagen cables, the neural wiring, the intricate hydraulic vessels. You can't just slap down some new concrete. The body physically loses the exact spatial blueprint it needs to rebuild.
So if we synthesize all of this, what does this actually mean for you? If we step back from the microscopic details, the periodontal ligament is a profound testament to the fact that human biology is defined just as much by the tiny, invisible spaces between our structures as by the major structures themselves.
That's a great point.
The true magic of your bite isn't in the rigid tooth or the solid jawbone. The magic is entirely contained within the 0.25 millimeter void that endlessly negotiates the relationship between the two.
I really want you, the listener, to take a second the next time you chew your food. Just pause and appreciate the microscopic, hydraulic, bungee cord suspension system silently taking the brunt of that force, constantly breaking down and rebuilding itself in real time just to keep you functioning.
It's doing a lot of heavy lifting.
And going through these sources leaves me with one final kind of wild thought for you to ponder. If human fibroblasts can flawlessly perfect balance the targeted destruction and total regeneration of complex tissues, nerves, and bone in a fraction of a millimeter, if scientists can eventually map and fully decode that exact regenerative mechanism, could that specific cellular logic be the ultimate key to regenerating entire lost limbs or vital organs in the rest of the human body? If we can figure out how the body naturally rebuilds the bridge, maybe one day we can rebuild the entire city. When you take a bite out of a really crisp, hard apple, you probably just think about the crunch.
Right. It feels like this simple, almost binary mechanical action.
Yeah, exactly. I mean, you bite down, the apple breaks, and you chew. We experience it as this singular, completely effortless event.
It requires zero conscious thought, so we take it completely for granted.
But the amount of sheer mechanical force required to fracture that apple is actually immense.
Oh, absolutely. If you were to look under the surface,
Yeah.
literally under the gum line, you would see that that simple crunch is anything but simple.
It's basically a biological miracle.
It really is. You are looking at a microscopic landscape that operates like this bustling, highly dynamic construction zone.
Just constantly destroying and rebuilding your jawbone to keep your teeth from falling out of your head.
Exactly.
Well, welcome to today's deep dive, and our mission today comes directly from you, our listener. You send over this incredibly detailed 15-part anatomical atlas.
It's a beautifully mapped out cellular blueprint of how your teeth stay rooted in your jaw.
Yeah, and I have to say, looking through the sources you provided, this is absolutely wild. We are going to completely unpack the architecture of your smile today.
And the overarching theme this atlas presents is fundamentally a story about a relationship between two vastly different tissues.
Right. On one side, you have something highly adaptable.
Highly plastic and constantly changing, which is the bone. And on the other side, you have something highly static, stubborn, and unyielding.
The cementum.
Exactly. The way these two tissues interact determines whether you keep your teeth for a lifetime or lose them.
Well, I want to dive straight into this blueprint. And to make sense of this, I have to compare a tooth to a house.
Okay, I like that analogy.
Right. So the shiny enamel, the part of the tooth that you brush and floss and look at in the bathroom mirror, that's just the roof.
We aren't really talking about the roof today.
No, we are heading down into the basement. We're looking at the foundation. According to this atlas, the basement consists of two main characters.
The alveolar bone, which forms the socket in the jaw, and the cementum, which is this incredibly thin layer coating the actual root of the tooth.
And the contrast between those two is stark, right?
Incredibly important for how we chew, yeah. That alveolar bone forming the socket is a high turnover environment. It's constantly remodeling itself based on the forces of your bite.
Tearing itself down and building itself back up.
Exactly. Meanwhile, that cementum coating the root is highly mineralized and has almost no turnover. It doesn't remodel.
It mostly just thickens very slowly as you age.
Right, just to repair minor damage.
And right between this ever-changing bone and this stubborn root coating is a gap.
Yeah, and that gap is filled with something called the periodontal ligament, or PDL.
The unsung hero of the human mouth, honestly.
Truly. It's a fibrous tissue acting like a living suspension bridge. It connects that static cementum to the dynamic bone and allows for microscopic movement.
Because if your teeth were perfectly fused to your skull...
They would shatter the first time you bit down on an almond.
Wow. Yeah, the ligament provides that tiny bit of give. Plus, it houses this massive neurovascular supply, bringing nutrients and sensory feedback to the area.
You got it.
So now coming to next slide, I want to bring up a really important question about the bone itself.
Sure.
If the jawbone is constantly taking the immense shock of chewing hard foods, why doesn't the bone just shatter? I mean, looking at the cross-sections in the atlas you sent, the bone looks almost hollow in the middle.
Yeah, that seemingly hollow look is actually a highly sophisticated layered security system.
Ooh, designed for shock absorption.
Exactly. The outer layer of your jaw consists of cortical plates. This is dense, compact bone. Think of it as the hard armor on the outside.
Okay, and it features those internal vascular highways.
Right, the diversion systems that pump blood into the thickest regions.
So that's the hard outer shell. But the inside is what looks spongy here.
That spongy interior is the cancellous bone. It's an intricate network of narrow, irregular bony branches called trabeculae.
And that honeycomb nature is the secret to its strength.
Absolutely. When you bite that apple, the force travels down the tooth, into the ligament, and dissipates right into that spongy, cancellous bone. It absorbs the shock so the hard outer shell doesn't fracture.
That's brilliant. And then there's the actual socket lining, the very edge of the bone where the tooth physically sits. The terminology in the atlas gets a little intense here.
It gives this lining 4 different names depending on what function you're looking at, yeah.
Right.
Biologically, it's called bundle bone because it houses the thick bundles of fibers from the ligament. Anatomically, it's the cribriform plate because it's perforated like a sieve with tiny blood vessels.
Okay, and structurally?
Structurally, it's the alveolar bone proper because it provides the direct bony support. And finally, radiographically, it has a name most listeners might have actually heard.
Oh, is this what the dentist is looking at on the screen?
Exactly. When you go to the dentist and they look at your x-rays, that socket lining shows up as a dense, bright white line called the lamina dura.
So if that white line is intact, your foundation is healthy.
Right. And if the line is broken or missing, the dentist instantly knows your bone's security system is compromised.
Wow. Now, coming to next slide, it's fascinating how the architecture changes depending on where you are in the mouth. The atlas compares the upper and lower jaws, and they look like entirely different construction projects.
They really do. The lower jaw, the mandible, looks incredibly neat and organized, like a horizontal ladder.
But the upper jaw, the maxilla, looks like a chaotic spiderweb.
The structural demands on those two bones are just completely different. The lower jaw is a dense, movable hinge. It takes the absolute brunt of the muscular force when you chew.
So because of that heavy unidirectional stress, its spongy bone is arranged in that regular ladder-like pattern.
Exactly. The atlas categorizes this as type I trabecular topography.
And I'm guessing the upper jaw is type 2 because it doesn't move.
Right. The maxilla is fixed directly to the skull. It doesn't hinge, and it has to make room for your nasal passages and sinus cavities. So its spongy network is irregularly arranged, multidirectional, and far more porous.
But regardless of whether it's upper or lower, there is a crucial topographical rule that governs both jaws, right?
Yes. This is the rule about how the bone compensates for the shape of the tooth root.
Right, so as the root gets narrower, as it goes deeper into the gums toward the bottom or the apical direction, the surrounding alveolar bone actually gets thicker.
The bone has to fill the void. As the root diameter tapers down to a point, the jaw predominantly expands its spongy, cancellous volume to fill that extra space.
It maintains structural integrity by wrapping the narrowest part of the root in the thickest blanket of shock-absorbing spongy bone.
It's highly efficient engineering.
It really is. Now, coming to next slide, I actually want to push back on a specific statistic in the biochemical blueprint you provided.
Oh, which one?
It states that 35% of this bone is organic matrix and water. I mean, I always pictured bone as pure, solid mineral, like a literal rock.
A lot of people do.
But if it's a rock, how can it be over a third water and organic material?
Well, if human bone were pure rock, it would be dangerously brittle. You would snap your jaw simply by grinding your teeth at night.
Ouch.
Yeah. A much better architectural analogy is reinforced concrete. The inorganic matrix makes up the other 65%. That's your hard minerals, primarily tightly packed hydroxyapatite crystals, calcium, phosphate, trace elements like fluoride.
Okay, so that represents the concrete. So the 35% organic part is the rebar running through the concrete.
It's the rebar, but it is entirely alive. That flexible scaffold is made almost entirely of type I collagen.
But scattered within that collagen are those critical non-collagenous proteins.
Right, like osteocalcin and bone morphogenetic proteins, or BMPs. These are chemical messengers.
They give the bone its living flexibility and its incredible ability to signal for local repairs and growth.
Exactly.
Well, now, coming to next slide, that perfectly sets up the cellular workforce. If the bone is this never-ending construction site of reinforced concrete, who are the foremen and the workers doing all the mixing and pouring?
We have 3 main cellular entities running the site. First are the osteoblasts. Think of them as the builders.
Okay, the builder.
They're small cells that originate from stem cells in the tissue, and their entire job is to synthesize the fresh, unmineralized bone matrix, the wet concrete, and regulate how it hardens.
So the builders lay the fresh concrete. Then we have the destroyers, the osteoclasts. And the illustration in the atlas makes them look like terrifying sea monsters.
They are biologically formidable. Osteoclasts are massive, giant cells with multiple nuclei. And what's fascinating is they don't originate from the bone. They originate from the blood.
Wait, really?
Yeah, they're born from the same tissues that make your immune cells, which explains why they act like little microscopic seek-and-destroy machines. They roam the bone surface, find a spot, and secrete powerful acids to actively melt and destroy old bone.
That is wild. And the third group are the osteocytes. The atlas refers to them as the managers. How do you get to be a manager on this construction site?
By getting walled in, osteocytes are actually just former builders, osteoblasts, that essentially poured concrete all around themselves and got trapped.
So they live inside tiny calcified caves.
Right. But from inside those little caves, they extend these long microscopic tentacles out into the surrounding bone to manage oxygen and nutrient transport.
And more importantly, they act as mechanical sensors.
Exactly. They literally feel the physical strain on the bone when you chew, and they send signals to the builders and destroyers telling them where to work.
Well, if these cellular workers are constantly tearing down and rebuilding the jaw based on mechanical strain, what happens when the anatomy itself sets them up for failure? Now, coming to next slide, the clinical section of the atlas shows these osseous defects that genuinely make me cringe.
Yeah, they can look pretty alarming.
I'm looking at fenestrations and dehiscences. How does a tooth end up with a literal window in the bone exposing its root?
It highlights a major structural vulnerability. In a perfectly healthy mouth, the bone curves beautifully over the tooth root, covering it completely. But a fenestration is exactly what you described, an isolated window where the bone is completely missing.
So the root is sitting right there, covered only by your soft gum tissue.
Right.
And a dehiscence. The visual for that looks even worse than a window.
A dehiscence is a complete loss of the top margin of the bone. It's like a cliff drop. Instead of a small window, a whole vertical strip of the root surface is completely denuded of bone all the way up to the top.
Why does this happen? The atlas notes this is most common on the facial side of the front teeth. Is it just bad luck?
It's usually a matter of spatial constraints. Think about the anatomy of your front teeth. Sometimes the roots are naturally prominent, or the teeth grow in tilted outward, pushing heavily against the bony plate facing your lips.
And because that plate of bone is already paper thin.
Exactly. The constant outward pressure simply causes the bone to give way over time.
Wow. Well, now, coming to next slide, I really want to zoom back in on the mechanics of those destroyers, the osteoclasts, the biological mechanism of bone remodeling.
It's a fascinating process.
Because the idea of a soft biological cell dissolving a rock just sounds like science fiction to me. How exactly does that happen?
It is an incredibly aggressive biochemical sequence. The cycle initiates when the bone is stressed, and signaling molecules called interleukins act like microscopic distress flares.
Calling for backup.
Right. They attract single-celled monocytes from the bloodstream. When they arrive, a chemical signal causes all those separate monocytes to fuse together into one giant multinucleated demolition machine.
The osteoclasts.
Exactly.
So they combine to form a megacell. Once they're assembled, what is step one of the demolition?
Step one is decalcification. The osteoclast attaches itself to the bone using a ruffled border. It acts like a microscopic suctioning cup, creating a perfectly sealed zone underneath the cell.
Okay, a sealed zone.
Then it pumps citric and lactic acids directly into that sealed zone. This drastically drops the pH, creating a highly acidic environment that literally melts the hard hydroxyapatite crystals.
Wow, so they just melt the concrete part of the bone. But what about the organic rebar, the collagen?
That requires step 2 degradation. Acid won't dissolve collagen. So once the hard mineral is melted away, the cell switches tactics and releases powerful enzymes like collagenase.
Like biological scissors.
Exactly. They chop up and break down the exposed collagen matrix.
So they melt the concrete and chop up the rebar. Where does all that waste go?
That is step 3 transport. The osteoclast acts like a vacuum cleaner. It sucks up all those loose mineral ions and chopped up amino acids, shuttles them through its own cell body, and dumps them safely into the bloodstream.
So the body can reuse those raw materials somewhere else.
Precisely.
That is just brilliant. Now, coming to next slide, this mechanism brings up such a cool contrast in the clinical data you sent over. We can actually manipulate this remodeling cycle.
We can, yeah.
When someone gets braces, it's essentially a controlled hacking of this system.
No.
But when someone gets gum disease, periodontitis, it's a total system crash.
That is an excellent way to frame it. Orthodontic movement with braces is purely mechanical and beautifully controlled. When the metal wire pushes your tooth in one direction, it creates a pressure side and a tension side inside the socket.
Okay, so on the pressure side, the bone is being squished.
Right. That mechanical stress increases levels of a cellular molecule called CAM-AMP, which acts as a green light for the osteoclasts. The destroyers are called in to melt the bone away so the tooth has room to move into.
And on the other side, the side the tooth is moving away from.
That's the tension side. The periodontal ligament fibers are being stretched tight. That stretching sensation tells the osteoblasts, the builders, to rush in and pour fresh bone, filling in the gap the tooth just left behind.
It's a perfectly balanced equation of destruction and creation.
It is. But periodontitis, severe gum disease, is the dark side of this biology.
Right.
Periodontitis is pathological. Bacterial infection triggers massive inflammation, and the immune system just goes haywire. Instead of a controlled remodeling, the body sends in the destroyers to relentlessly eat away the bone to run away from the infection.
It causes unpredictable, chaotic destruction.
Yeah. And the atlas highlights a very sobering clinical reality. Once that alveolar bone is destroyed by periodontitis, biologically coaxing the body to regenerate even a few millimeters of it remains the absolute greatest challenge in modern dentistry.
Wow. Well, now, coming to next slide, let's pivot to the other half of this biological foundation. We've talked about the dynamic bone socket. Now let's look at the static root coating, the cementum.
The avascular root shield.
Right, the avascular root shield. If the bone socket is already gripping the tooth, why does the root need its own bloodless shield?
Because without the cementum, the periodontal ligament would have absolutely nothing to anchor to on the tooth side. The cementum is a calcified tissue that tightly hugs the root. Its primary biological job is to act as the attachment surface for the fibers of that suspension bridge.
And the sources show two different types of fibers embedding themselves into this shield, extrinsic and intrinsic.
Right. The extrinsic fibers are the famous Sharpie's fibers. These are produced externally by the cells in the ligament. They act like thick cables that plunge deep into the cementum from the outside.
And the intrinsic fiber.
Those are the structural matrix fibers produced internally by the resident cells of the cementum itself, the cementoblasts.
The adaptive dynamics of this shield are fascinating. The atlas notes that it constantly deposits new cementum at the apical area, the very bottom tip of the root. Why is it constantly growing at the bottom?
It's an ingenious evolutionary compensation mechanism. Over decades of eating, the biting surface of your enamel slowly wears down. It flattens out.
Right.
So to keep your upper and lower teeth in active contact so you can actually chew your food, the cementum at the bottom of the root continuously thickens. It essentially pushes the entire tooth microscopically upward over your lifetime to compensate for the wear at the top.
That is amazing. Now, coming to next slide, that brings up a massive paradox in the composition chart.
Which part?
We keep calling it a shield, but this breakdown says cementum is only 46% inorganic matter. That makes it significantly softer than the alveolar bone we just talked about. If it's a shield, how does being softer help?
It comes down to toughness versus hardness. It doesn't need to be as hard as bone because it doesn't absorb the heavy impact. The bone does that. The cementum's remaining 54% is organic matrix and water.
So that makes it incredibly tough and slightly pliable.
Exactly, which is exactly what you want for an anchoring surface. If it were completely brittle, the ligament fibers would just rip right out of it under high tension.
That makes sense. And looking at the topographical heat map, the thickness of this shield is wildly uneven.
It is. Up near the crown of the tooth, right by the gums, it's hair-thin between 16 and 60 micrometers. But down at the very bottom, it's thick and highly active, around 150 to 200 micrometers.
That beautifully reflects the continuous growth at the root tip we just discussed.
Right. But there's another fascinating detail on this thickness map. The cementum is consistently thicker on the distal surfaces, the back-facing side of your roots, compared to the front-facing side.
Wait, why would the back of the tooth root need thicker cementum than the front?
Because of a phenomenon called mesial migration. Throughout your life, your teeth have a natural tendency to slowly drift forward toward the midline of your face.
Oh, wow.
Yeah, and as the tooth inches forward, millimeter by millimeter, it places tension on the back side of the socket. That natural tension stimulates the back surface, the distal side, to constantly produce more cementum to maintain its anchor as it moves.
That is wild. Now, coming to next slide, this leads us into a slightly intimidating section of the atlas. I'm looking at a true alphabet soup of acronyms classifying cementum architecture.
Yeah, it can look a bit overwhelming at first.
You've got AAC, AFC, CMSC, CIFC. I mean, instead of just listing letters, can we translate this into a functional geographical map of the tooth?
Absolutely. The best way is to just ditch the acronyms and think about the geography of the root from top to bottom.
Okay, starting at the top.
Right. So at the very top, sitting exclusively over the enamel near the gum line, you have this tiny, bare layer. No fibers and no cells. It's really just a seal.
Okay, so a bare seal at the top, moving down to the upper half of the root.
The upper half is the primary anchor zone. It's packed full of those dense external Sharpie's fibrils we talked about, but it has no living cells inside it. It doesn't need to grow. It just needs to hold the tooth firmly in place.
Got it. And as we move to the bottom half?
The bottom half and the furcations, the areas where the roots split, those are the active growth zones. This area is packed with living cells and mixed fibers because it's constantly adapting, thickening, and pushing the tooth upward to compensate for wear.
That makes perfect geographical sense. The atlas also lists two utility players down there, a patch layer and a glue layer.
The patch layer is a specialized cellular cementum that rushes in to fill microscopic potholes or areas of root damage. And the final layer is an intermediate hyaline zone.
Which is like the glue.
Exactly. Think of it as industrial-strength biological glue that binds this entire complex cementum structure to the inner dentin of the tooth.
Nice. Now, coming to next slide, that brings us to exactly where this root system meets the visible crown of the tooth, the cement-enamel junction, or CEJ.
Right, the transition zone.
The anatomy here reminds me of tucking a shirt into your pants. Ideally, you want a clean, secure line where they meet. But apparently, Mother Nature is a terrible tailor, giving us this 60-30-10 rule.
That's a brilliant way to visualize it. The 60-30-10 rule explains how that cementum shirt meets the enamel pants at your gum line. 60 to 65% of the time, the cementum slightly overlaps the enamel. It's a secure, protective tuck.
And 30% of the time, they meet perfectly end-to-end, completely flush. But the atlas has giant warning signs around that last 5 to 10%. What happens if the shirt completely pulls out of the pants?
Well, 5 to 10% of the time, the enamel and the cementum fail to meet entirely. A physical gap exists. This is critical because it leaves the underlying dentin completely exposed to the oral environment.
And dentin isn't a solid wall, is it?
No, it's full of microscopic tubes that lead straight into the nerve center of the tooth. If you have this specific anatomy and you drink a glass of ice water, that cold temperature travels straight down those exposed tubes to the nerve.
Which is the primary anatomical reason for severe tooth sensitivity.
Exactly.
That explains so much about why certain teeth randomly hurt. Now, coming to next slide, speaking of things going wrong, the pathology section illustrates some wild extremes.
Oh, yeah.
The illustration for hypercementosis shows a tooth root covered in these massive, crazy spikes and nodular boulders. What causes the cementum to uncontrollably mutate like that?
It's an aggressive overgrowth triggered by abnormal mechanics. If an orthodontic appliance pulls on a tooth with excessive, continuous tension, the body panics and dumps massive amounts of cementum to secure the anchor.
Or if you lose a lower tooth.
Yeah, the upper tooth opposite to it loses its biting partner. It will just keep growing downward, wildly laying down cementum boulders, searching for something to bite against.
That is terrifying. And the opposite of overgrowth is resorption and exposure. The gums recede, and the cementum is left out in the open.
This is an incredibly common and frustrating clinical issue. When your gums recede due to aggressive brushing or inflammation, that incredibly thin, soft cementum near the crown is suddenly exposed to the mouth.
And because it's soft and highly permeable,
microscopic bacteria penetrated instantly.
Yeah.
This leads to root caries cavities forming directly on the root of the tooth, which are notoriously difficult for a dentist to drill and fill.
Yikes. Well, now coming to next slide, this entire anatomical journey brings us to this incredible synthesis slide, the dynamic attachment apparatus.
It's a great summary visual.
Looking at this diagram, you truly see the living suspension bridge. You have fibrous cables bolted into living, remodeling, sensor-packed stone on one side and a hardened, slowly growing hull on the other.
The beauty of this apparatus is its profound interdependence. You have these distinct tissues performing one unified critical function. The avascular cementum statically anchors the bridge.
The highly plastic alveolar bone constantly models and remodels to absorb the chaotic mechanical shock of chewing.
And the Sharpie's fibers physically lock these two distinct worlds together. If any single one of these three elements fails, the biological success of the tooth is over.
It all has to work together perfectly. Now, coming to next slide, looking at the final master topography takeaways you provided, listener. If we had to hammer home the ultimate so what of this entire deep dive, what are the 4 cardinal rules we're walking away with?
First, bone is highly plastic. It's brilliantly designed to adapt to mechanical stress, but terribly susceptible to rapid, irreversible destruction from bacterial disease.
Second, socket architecture dictates support. The structural stability of your bite relies entirely on whether you're looking at the dense lower jaw or the porous upper jaw.
Third, Cementum is avascular and adaptive. It acts as a bloodless shield that constantly compensates for age and wear, thickening at the bottom to maintain your bite over decades.
And the fourth rule.
The fourth rule is that the tissues are interdependent. The tooth survives entirely on the delicate, lifelong interplay between the dynamic socket, the static root shield, and the fibrous bridge connecting them.